Good morning and welcome to all of you. Thank you for joining us this morning to the first in our series, Brain Talk, Seizures in ASD by Dr. John Gaitanis. Welcome, Dr. Gaitanis. This talk is sponsored by the Brain Foundation. Our goal is to catalyze discovery and translational research leading to FDA-approved treatments to benefit individuals with neurodevelopmental disorders, including ASD. Please go to our website for more information about these talks and also our upcoming conference, Synchrony, in July. The website is listed below, brainfoundation.org. I know you're all here to listen to Dr. Gaitanis, so I will introduce him and he will be presenting for about 45 minutes, and then I will speak a little bit about the foundation before we turn over to questions. Dr. Gaitanis is a graduate of Brown Medical School and he completed his neurology at Children's Hospital, Boston. He went on to finish Epilepsy Foundation at Beth Deaconess Medical Center before returning to Children's Hospital, Boston to join their epilepsy staff. While there, he co-founded the Comprehensive Brain Malformation Program, helping bridge clinical and basic science knowledge of these conditions. In 2004, Dr. Gaitanis returned to Brown Medical School and Hasbro Children's Hospital, where he served as Director of Pediatric Epilepsy. He aided in the development of ketogenic diet and epilepsy surgery programs at Brown, providing comprehensive epilepsy care for children in Rhode Island. Dr. Gaitanis currently serves as Director of Child Neurology at Tufts Medical Center, floating hospital for children. Apart from his clinical duties, he serves as the Chairperson of Matthew Siravo Memorial Foundation's Scientific Advisory Board, a nonprofit dedicated to improving epilepsy advocacy and education. His research is aimed at improving sensitivity of EEG through DSP, and he has also published original articles and book chapters on status epilepticus, cortical malformations, and epilepsy in infancy and childhood. Thank you once again, Dr. Gaitanis, and he's also a great champion of the ASD population. Thank you so much for coming here, and I'll hand over for you to start sharing.
Yeah, thanks for that introduction. I appreciate that. And that is true that a lot of my focus is really more in the autism world. Some of what my training, though, really was primarily in epilepsy originally. And so it's the two share, unfortunately, they're very commonly associated. And it's about a third of kids with autism who have epilepsy. And so it is really important to think of these as just different sides of the same brain, and to approach treatment in ways that think about the whole child and don't necessarily like compartmentalize each individual issue. And there's some very unique aspects to how we manage epilepsy and autism. And I know there will be a lot of very specific questions that come up, and I'll be happy to try to address as many as we can. I hope I'll be able to address many just through the talk itself, and hopefully give some of the tools for those who are interested in really understanding the aspects of epilepsy in better detail. It's always good to just be clear about what exactly is epilepsy when we use that term, and what is seizure. So when we talk about seizure, we're really describing a clinical episode that results from an abnormal firing of cortical neurons. So we think of this really as an electrical short circuit is one very simple way to think of it, and it's a short circuit that's causing an actual clinical symptom. Whereas when we describe epilepsy, what we mean by that is that there are recurrent and unprovoked seizures. So for example, a febrile seizure would not really count quite the same as epilepsy because of the provocation of fever. Or if you had, say, meningitis or head injury causing seizure, then that doesn't necessarily constitute epilepsy. It's really when it is unprovoked and repeats itself, then we term it as epilepsy. We can use the term epilepsy in someone who's had one seizure as long as they have an abnormal EEG and show that there's a high potential for epilepsy recurrence. And when we look at epilepsy, it's really something that we see mostly in the two extremes of life. So it's more, the incidence is higher in children, and then it actually sort of dips in young adulthood, and then it really takes off again as we get older, largely because of stroke. And so the causes here are mostly stroke or brain tumor, things that happen in older people. The causes here in childhood are really quite varied. And so when we think of epilepsy, just like when we think of autism, each kid is very individual. There are many, many causes. Epilepsy, in a sense, is more of a symptom rather than an actual disease. The causes are quite varied and many. And I'll give you an example of where I think, using a case example, I'll give you an example where I think epilepsy and autism together is quite different in terms of how it presents than, say, epilepsy alone in childhood. This is an actual patient I'm presenting, but he's really representative of like so many of the kids that I see. And so he's now 18, but when you going through his history, he was doing quite well, really, in those first 2 years. He was walking, he was communicating pretty well. He was very social. He was using single words right around 12 months at a normal time. Started 2-word phrases around 2 years. So everything really was progressing well. But it was around that time, around 2 years, that he had these frequent bouts of otitis media. He had frequent infections, lots of antibiotic rounds. And it was at that point where there was a developmental regression. So he stopped using words, stopped babbling, really, really frequent irritability, could not be consoled, head banging. Parents had to take him on long car rides to help quiet him. That was the only way they can actually get him comforted. And then of course, then you have to do this very difficult dance of how do we get him from the car, once asleep and calm, how do we get him from the car back to the house without waking him? Sometimes that would lead to yet another car ride. And so really a very difficult time to manage these symptoms. It was around 28 months when he was diagnosed with autism. At that point, he really had a very profound regression. He was not using words, was not babbling, had really lost that social interaction that he previously had. And it was then when he began ABA. And there was some slow developmental progress that happened through elementary age. Started to use single words, but more towards labeling. Did require a lot of prompting. Did pretty well through about 12. So for about 3 to 12, like things are relatively steady. Life was pretty good, but it was around 12 where things changed yet again. And it was at that time when 2 major things had happened. One was that he had his first generalized tonic-clonic seizure. It was pretty prolonged. Both an MRI and EG were normal at that time, but despite the normal studies, the second seizure still happened a month later. And he was started on medications at that point. But at that same time, like just after that first seizure happens, there's also this pretty massive increase in OCD, more meltdowns, self-injury, striking himself, striking caregivers, a real departure from what had been seen previously. And this is taken from the internet. It's not the actual patient, but very representative of what these head strikes would be. They're often at the temple, around the eye, repeated strikes that were with significant force, enough to cause bruising, certainly enough to warrant concern about concussion or things like post-concussive syndrome. And of course, for a patient with seizures, the last thing we want is to start inducing concussion. So it really prompts a lot of concern in how these things are interacting. And one thing that was, one thing that I guess has persisted, so now he's 18, but since 12, there has been this combination of both seizures and self-injury. And they've been somewhat interwoven in his life. So the self-injury often comes on related to OCD things, transitioning, or anything that interrupts the need to perform certain behavioral tasks or to satisfy that OCD need. And because he's quite a bit bigger, it's also made that aspect very problematic to manage. But what's really kind of interesting is that when you see this buildup of behavior, it sometimes precedes a seizure. So this is where the two are sort of interwoven. So just as they came on around the same time in life, if you look at it over a much shorter time scale, they sometimes come on within the span of days, so that there's a buildup of OCD, then a seizure happens, and then so you kind of know when this will happen. Sleep is also disrupted, so he'll go a few nights without sleep, really STEMI, much more aggression and self-injury. That's when we know the seizure is very highly likely. Then a seizure would happen, and then the behavior is calm again for a period. So it's almost like coming in waves, and the two together. And I think one thing that this makes me think about is like, would we actually categorize what happened at age 12? Is that almost like a second regression? This is something that I think is something to consider, is that the initial regression maybe has some relationship to the subsequent regression. And in a way, you can almost think of each of these waves of seizure as almost like repeated smaller level regressions that are occurring. But what I mean by that second regression is, there's an initial regression around 2 years. Then you have like a period that's pretty steady, but then suddenly around 10 to 14, epilepsy develops and self-injury and aggression develop together. And they have a tremendous impact on life, on all aspects, academically, socially, really everything. This is a story, I'm presenting a single patient, but this is a story that I have personally seen repeated time and time again. The ages may vary a little bit, but there's some consistency. And the other thing that's been really interesting when we think about this sort of second regression is that the workup is often unrevealing. Those initial EEGs are very commonly normal, and the MRI is often normal too. And so this is very different than when we evaluate someone for epilepsy alone. There's much higher probability of seeing some abnormality on either EEG or MRI when we think about epilepsy itself. And the age here is a little bit unique too. Why is it suddenly around adolescence that things seem to change? Is it a hormonal change? Is there something else that leads to this change at this time in life? I don't know those answers, but something I've seen repeated certainly. And I would be curious too, if from the audience, if this is a story that rings true with many. It does for me, at least. It's something that I've seen quite a bit. But certainly feel free to share that if it is something that seems to ring true. When we think of autism and epilepsy together, though, a lot of the research thus far is focused on younger kids. So one challenge here is that much of the research in autism and epilepsy has really looked up until about age 5 or 6. Those studies, I think they're clearly going to miss a patient like the one I'm presenting. So in order to really capture the full scope of autism and epilepsy, a study really does have to look at an older age group. And the same is true when it comes to things like self-injury or aggression. I think we really have to include adolescents if we're going to understand the full scope of these challenges. But as I said before, it's about a third of kids in both directions who would have both conditions. So if you look at autism, about a third of kids with autism will have epilepsy. And if you look at epilepsy, about a third of kids with epilepsy will have autism. And so there's a very, very high co-occurrence of these two conditions. I don't think of it so much as a comorbidity. I just think of it more as I think of it more like these are different symptoms of the same underlying condition that's affecting the brain. And there are some key differences, though. So one is that you have some situations where the epilepsy is the initial presentation, and sometimes at a very young age. So, for example, infantile spasms present typically around 6 months of life. Dravet syndrome also presents around 4 or 6 months of life. Dravet syndrome is interesting because those kids have very commonly they have that initial seizure following vaccination. Anything that triggers an inflammatory response or fever will really worsen their seizures. And so a very common story is that they would have their routine 4 or 6 month immunizations, and then pretty much that night or the next day will go into a very prolonged seizure. And their focus remains seizures really through about age 2. And it's around that time that the developmental concerns seem to become a little more noticeable. But early on, the developmental issues are not quite as noticeable. And they very commonly have autism spectrum. And infantile spasms has a little bit of a similar characteristic. You really focus on the seizures at first. The developmental concerns are sometimes overshadowed. In both of those conditions, the autism diagnosis is sometimes very delayed because the emphasis on seizures and epilepsy has overshadowed development for sometimes the first 5 or 6 years. And we just simply didn't pay enough attention to development. But then you have other forms of epilepsy where the child clearly had developmental concerns first, and then some years later developed seizures, a little closer to what I had presented with our patient. And these are fundamentally very different circumstances. So as I say, just like in autism, we can't lump all kids together. Each child is very individual. The same is true in epilepsy as well. One other factor, though, that's very important to think about when we think of epilepsy is that for some kids, they may not always have seizures as the primary issue. There are some kids where their primary problem may relate more to the physiology that's occurring during sleep. And so what we term this Landau-Kleffner syndrome or electrical status epilepticus of sleep. And what we're describing by this is a situation where when the child falls asleep, their brain physiology is such that they develop very frequent spike waves. This is what a spike wave looks like. So it looks like a spike. Here is a spike wave. So when we use the term spike, it really looks like a spike, which is why we use such a term. These lines are the 1 second marks. So these spikes are occurring a little more frequently than 1 per second. And if you look at this page, it's almost the entirety of the page has a spike wave on it. And this is what happens to some children when they fall asleep. And this is not a seizure. However, one could reasonably imagine that this must affect the quality of sleep. And sleep is critical for everything we do, everything the brain does. So when we think of the importance of sleep, sleep is a time when the brain is able to consolidate memories. That's one of the key factors in sleep. But it's also a time when the brain is able to flush all of the waste products of metabolism out. So we produce more spinal fluid. All the buildup products from our metabolism through the day are able to kind of reset and sort of flush out through that spinal fluid. And if we don't get into a healthy slow wave sleep, we can't consolidate our memories. We can't reset our metabolism. So it's almost like having this occur in sleep is almost like running a marathon every night, like in your brain, not giving it any chance to rest. And that can have a pretty profound developmental consequence. So we do have to think, when we think about autism and epilepsy, we have to think, are the seizures or the spike waves themselves affecting language or development? In this particular case, these spike waves are in the language center. These are over the left temporal region where language is. So these kinds of spikes can directly affect language. We also have to think, do the medications that we use for epilepsy, do those have a developmental consequence? And so we have to always think about what do our treatments do to kids? Are they going to be good developmentally? Are they going to be good behaviorally or not? And so these variables are always what we're trying to juggle when making treatment decision. And so one thing to note, though, Landau-Kleffner, when I talk about this situation or electrical status epilepticus asleep, this situation where children will have frequent spike waves in sleep, they can have language regression. It's somewhat similar to autism, to a regressive autism. So when kids have autism with regression, that usually happens around 2 years. In Landau-Kleffner, the regression is much later. It's after 3, but sometimes quite a bit later. It could be 5, 6, 7 years of age. And it's a little similar to what we used to term disintegrative disorder. In disintegrative disorder, this is a child who has aggressive autism after age 3. Those kids with disintegrative disorder, they have a very high incidence of epilepsy. About 70% of them actually have epilepsy. So there is a subpopulation of kids who seem to have a much later regression related to the onset of epilepsy or related to those spike wave discharges. So we always have to be conscious of this. And in kids who have a history of regression, it's something that I think we always have to consider. And for some patients, some of you may have actually undergone an EEG without a history of seizures. And this might be one of the concerns that perhaps the neurologist had, is being certain that there was not something like this going on that was silent and might have been affecting either sleep or development. So what I'd like to kind of segue to, though, is how this population of kids who have both autism and epilepsy, they are really different than epilepsy alone. And I think the neurologist has to be trained in really thinking about what those differences are and approaching treatment in a way that's good for both sides of the same coin here. Like we don't want to use epilepsy treatments that are bad for language or development. We also don't want to use medications for, say, behavioral concerns that are actually going to bring out more seizures. We have to think of the whole child. And so one thing that our group at Brown has done is we've really looked specifically at the population of kids who have both autism and epilepsy and tried to understand, are there differences? This is a very busy slide, but one thing that stands out is that kids with autism and epilepsy both, they generally will have more of a generalized motor seizure, more commonly than kids with epilepsy alone. So that's one key difference between groups. They're less likely to go into status epilepticus, meaning a prolonged seizure as well. So the kids who have history of really prolonged seizures, like over half an hour, are more commonly just in the epilepsy alone group. And kids who just have epilepsy alone are a little more likely to be classified as having an epilepsy syndrome. What I mean by that is that there are some, in childhood, there are some types of epilepsy that follow a very characteristic pattern, and we classify them as an epilepsy syndrome. So, for example, childhood absence epilepsy, what we term petit mal seizures, is an example of an epilepsy syndrome. And so kids with autism and epilepsy are less likely to be categorized under such a heading. The patient I presented would be an example of that. So he actually had a generalized motor seizure. He had an 8-minute seizure. It wasn't quite status epilepticus, long though, frighteningly long, but not what we technically classify as status. And he did not fit an epilepsy syndrome. So he's a little more classic for what we think of within the population of autism and epilepsy. And the other thing that's worth noting is that you're more likely, in autism and epilepsy, you're more likely to have a normal MRI than in patients with epilepsy alone. It doesn't mean we don't do an MRI, but it's something we just have to consider that there's a higher likelihood it may be normal. Medication choices can be different too. And one reason for this is that we have to always think about what the behavioral side effects will be on medication. So, for example, levetiracetam, which the brand name for which is Keppra, is not used quite as much this is within our patient population, but is not used quite as much in patients with autism as it is in the general population. Whereas lamotrigine, which the brand name is Lamictal, is used more in autism than it is in just the epilepsy population. And so there are reasons for that. So levetiracetam, anybody who's had their kid on it will likely know that levetiracetam is commonly associated with behavioral side effects. So it causes a lot of irritability, sometimes aggression. Really, you have to be very cautious about worsening those symptoms. Whereas lamotrigine is much less likely to cause those concerns. And lamotrigine is interesting because there was a recent basic science study that was done in animals that suggested that maybe levetiracetam can actually improve some of the core symptoms in autism. And so I feel a lot of questions about that about a year ago when that article came out. Let me know too if I'm getting a message on my internet is a little unstable. So if it staggers, just let me know. You can leave that in the comment if the sound is staggering. And then other things to think about too is in the population of kids with autism and epilepsy is that there may be some differences in terms of how the treatment response looks or how things behave over life. One thing that's interesting to note is that it's important to recognize is that overall, whether it's a generalized tonic-clonic seizure or a non-generalized tonic-clonic seizure, the seizure frequency does tend to get better as kids get older. In these really early age groups, would be the kids I mentioned before, like either Dravet or infantile spasm. They usually have very high frequency. As we move towards life, the frequency generally does improve as we move towards adulthood, which is a very good, reassuring thing to note. The other thing to know is that when we look at different treatments that we use, there are clearly differences in what parents report for efficacy. So if you look at all of the seizure meds and their efficacy ratings by parents, ketogenic diet actually rates really at the top. So the keto diet rates above the standard seizure meds in terms of efficacy. Atkins, modified Atkins, SCD, the specific carbohydrate diet, those are all, and gluten casein-free diet, have all been looked at here, but of those, the keto was the one that seemed to rate the highest as far as efficacy. When it comes to meds, we don't use primidone much. It's very sedating. So even though the efficacy is rated high, I would say the side effects are generally high. But you can see that valproic acid, levetiracetam, lamotrigine are really towards the top here. But the levetiracetam is the one I mentioned we have to be careful with due to side effects. And I would say that's true for the primidone and phenobarbital as well. The reason Topamax you might see used a lot is Topamax is one of the few medications out there that causes weight loss. And so for kids if they've been on Risperdal or Abilify and had significant challenge with weight gain, this may be one way to try to balance that, is to try a medication like topiramate, which can potentially improve that. It's worth noting the keto diet will also do that. So I don't use keto per se, though. So I don't really use the true keto diet so much because for that, you have to weigh and measure everything. And we would often have to initiate it by admitting the child to the hospital. What I prefer is to actually use a low glycemic diet. You don't have to weigh and measure everything. You simply have to keep carbs low. You're generally below about 30 grams of carbs a day for a low glycemic diet. And you're actually, when you do a low glycemic diet, if you're taking fewer than 30 grams of carbs, you're probably gluten-free as well, or it's very easy to be gluten-free. So you can do these two together without much problem. A little harder for casein-free. If you're doing a low glycemic diet, it may be a little more challenging to avoid all milk products, but that's an important thing to establish. If your child is very sensitive to casein, we definitely need to know that going into a low glycemic diet because many of the recipes call for milk or yogurt or other milk products. But whereas the gluten is the easy part because that's really being cut out for the most part. The other thing too, when you go gluten-free, and if you go low glycemic or modified Atkins, you're removing gluten. You're also likely removing a lot of the herbicides we use. So glyphosate is probably going to be pretty significantly reduced. What the actual relative importance for that is, we're not quite sure yet, but that's still an important thing to think of, is that there may be multiple variables there that are relevant. I'm just going to scan the questions real quickly, and you can let me know if okay, good. You just let me know too if there are any pressing things that you want to stop and focus on. I'm happy to do that. Otherwise, I'll try to address as many questions as we can after. So one thing too, I think that's important to note is, I've noticed this trend of the epilepsy and regression together, and I've noticed it mostly in kids who had a history of regression. So I really do think that the population of kids with autism who've had a developmental regression around 2, I think are fundamentally very different than many of the kids that we see. I think there's something very unique about that population. And one thing I did wonder about is whether a regression is something that is but whether the regression will predict epilepsy and will also predict aggression. And so and then it looks like a hand is up too. I'm happy to pause if someone has a question that they want to address now at this part of the lecture. I don't know if I have to. It might not actually, because it's set as, hold on. I have to allow you to talk. There you go. I'm happy to allow you to talk if you had a question you want to address now. If not, I'll continue on. Oh, that's okay. That's fine. So I'll just continue on then. So in my own patient population, I tried to look at this question, and what I found is that for patients who had a history of regression, the prevalence of epilepsy is actually pretty high. So within my own patients, I have a little bit of a skewed population because I am a epileptologist too. So I'm going to see more epilepsy than most. But about half of the patients that I'd see who had a history of regression actually had epilepsy. Whereas without regression, it was a little closer to the 1/3 that is often quoted in publications. The other thing that was interesting is that those who had a history of regression when they were about 2 had higher incidence of aggression as well, so, or self-injury. So that was about almost 3/4 of kids with history of regression who were exhibiting aggression or self-injury. And if I look at them all together, those who had a history of regression, about 45% or so had both epilepsy and aggression. So just shy of 50%. And then whereas about 1/4 without regression will have both epilepsy and aggression. And so this was achieving significance too. So it seems very clear that history of regression is something that is going to create this higher risk of both epilepsy and aggression as kids get older. And so there may be something to this history that is really important. That I think the reason it's important is to understand why the initial regression happened in the first place, because understanding that may help us better treat some of the core symptoms in autism. may help lessen the severity of that regression and may hopefully help bring that child to a better developmental trajectory early on. But the other thing too is if we can truly understand what causes the regression, maybe there's some chance that we can actually prevent the epilepsy or perhaps more effectively treat the epilepsy than just using anti-seizure medications, because there might be something more, whether it's related to mitochondrial functioning or inflammation, there may be some other mechanism that we're missing in our current treatments. And so that's kind of what I term like a second regression syndrome. And I think it's a pretty common concern in kids who I see who have both autism and epilepsy. The other thing too that's worth noting, and this was true in the patient I presented, is a lot of the kids I see who have a history of autism, especially with regression, if they present with the first seizure, when we do the workup, the EEG is normal, the MRI is normal, and yet they go on to have epilepsy. And so I actually think the risk of epilepsy is higher in that population as well, and they may need to actually start treatment sooner than others. So for diagnosis, I think the key here is really understanding root causes. And this is very different than what we do, say, for epilepsy itself. Like, so if you look at epilepsy, the standard is to do an EEG and an MRI. The MRI is looking for a structural cause. Like, so, we want to make sure there hasn't been a brain tumor, there hasn't been prior brain injury, a developmental abnormality of the brain, things like that. And the EEG is trying to figure out if there might be perhaps a genetic form of epilepsy. But as I mentioned, in this population of kids with autism and epilepsy both, sometimes those studies are both normal. And I think we're more commonly left without a clear-cut cause or etiology. And so some of these things, they could relate to a lot of different concerns, things like neurotransmitter disorders. This in particular is showing glutamate, but I think there are some situations, and this is like really a hyperexcitable situation that we would see in Fragile X, where glutamate is overly expressed. It's the excitatory neurotransmitter. And the other area that we could see where you see both autism and epilepsy are in situations where there's like a disorder of growth regulation. In particular, mTOR really holds a lot of importance. This is the mammalian target of rapamycin, and it's important for conditions like tuberous sclerosis and neurofibromatosis and Cowden's, all three of which are associated with autism. But what's important here is that our anti-seizure meds that we use do not affect this pathway of growth regulation at all. And so what we're doing is we're kind of putting a Band-Aid on it, but we're not really getting at the underlying cause for those kids. And channelopathies I mentioned, that would be like Dravet syndrome. So in Dravet syndrome, that's a SCN1A mutation. It affects sodium channels, very specific here in terms of treatment avenues. So these kids who have a sodium channel problem, they should not take a sodium channel blocking medicine like oxcarbazepine, because that would make seizures worse. And they actually respond better to treatments that we don't use in other forms of epilepsy as commonly. So, for example, Epidiolex, which is cannabidiol, is particularly effective here. And fenfluramine, which has also been used for weight loss in the past, is another very effective treatment, which we would not use typically for other forms of epilepsy. And then we have to think about metabolic things. So I'm showing a mitochondrion here. So the mitochondria are really the powerhouse for our cells. And of course, the brain is really one of the most metabolically active organs of the body. And so the brain is so dependent on good mitochondrial functioning. And in kids who have a history of regression, I think it's an important area to consider, is that we know something occurred that created a significant aberration of development. And knowing just how energy dependent the brain is, I think we always have to be cognizant of the possibility that perhaps mitochondria are at the heart of that regression, or maybe at the heart of the epilepsy. And are we actually doing something to support mitochondrial functioning? In most situations of epilepsy, the answer is no. We don't typically treat epilepsy with any kind of mitochondrial cocktail of vitamins. That's how we would usually support mitochondrial functioning is through vitamins and supplements, not so much through prescription meds. And of course, we have to think about immunologic factors too. So here, I'm showing the NMDA receptors. So NMDA is a type of channel for glutamate. It's the excitatory neurotransmitter. And if one has antibodies that attach to the NMDA receptor, it can activate the receptor, causing more excitation. And that's the sort of brain on fire situation that can cause sometimes psychosis or epilepsy, sometimes in older kids or young adults. They can be associated, in particular with ovarian teratomas, can sometimes trigger this condition. So a little more common in women, but than men. But there has actually been in kids. I mean, there was one case report of a patient with an autism and regression who was positive for these antibodies. So it might be something still worth exploring. And it's worth noting that just in epilepsy in general, there's quite an extensive body of literature demonstrating the importance of inflammation in terms of both how epilepsy develops and then also how the seizures themselves can worsen. And yet, when we think about anti-seizure meds, we don't typically treat seizures with immunologic approaches. And it might be an area that we have to think about. When we think about the aggressive behaviors, self-injury, the flare-up of OCD, I think it raises a lot of similar questions. Like, what is the role here for inflammation? Is there some interrelationship with PANS pandas and the epilepsy? And so that might be another area that's being, in addition to the metabolic, it might be another area that's being overlooked perhaps in some of our treatment considerations. And so I think what I'm trying to present here is that when you look at autism with epilepsy, I really think this is a unique subpopulation. We have to think about these kids differently than we do, say, kids with epilepsy alone. And so I don't think we should just go ahead with the standard epilepsy approach as we typically do. I think we really have to think about that child individually, think about the underlying mechanisms, and then also think too about how these medications we use might interact with both behavior and development. As we think about treatment options, though, why do we treat seizures? So, the biggest thing is we really want to lower the risk of injury. And we want to obviously avoid prolonged seizures. I'll talk a little more about this entity, but this is the most concerning entity, and it kind of has to be spoken of, because if we don't speak of it, like, we can't prevent it, we can't address it. But there is this entity of sudden unexplained death in epilepsy, and epilepsy unfortunately does have potential mortality associated with it. And I have more on this later in the talk about what we could do to prevent this. But overall, the risk in patients with epilepsy is about 1 per 1,000. But that's pretty frightening when it's your kid that you're trying to protect. That's still a pretty frightening number. It sounds low, but it's not a number I think any of us feel comfortable with. And it's yet another reason that we have to treat seizures. And then we also want to prevent the cognitive effects of seizures. And we want to obviously improve quality of life. We want to make sure kids can go out and do activities, do field trips, do things with their school, and not be limited due to the seizures. Typically, like in a neurotypical patient, we usually don't treat the seizure until the second seizure, because after one seizure in a neurotypical patient, the risk of epilepsy is about 50%. After a second seizure, it's about 80%. I do think in patients with a history of autism, that risk of epilepsy is probably higher after the first seizure, but that hasn't really been studied. But when we do treat, our goal is to be seizure and side effect free. And so we really want to achieve both. And what does the side effect profile look like? In general, I'll just give you a quick overview of what the treatment considerations look like. But when I say partial, that means the seizure arising from one part of the brain. Very commonly, we would use medications like carbamazepine or oxcarbazepine, like trileptal or tegretol, or we might use things like levetiracetam, lamotrigine, for those types of seizures. Whereas if it's a generalized tonic-clonic seizure, we're more likely to use valproate, which is Depakote, lamotrigine, or levetiracetam. So some slight differences based on whether it's a generalized seizure or partial. Absence seizures are what we used to call petit mal seizures. Those are the staring spell seizures. And there, in younger kids, we use a medication called ethosuximide or Zerontin. Whereas if that doesn't work, we might consider, again, levetiracetam or valproate. So you'll see a lot of the same meds mentioned for these seizure types. It's just worth noting, though, that in certain types of seizures, like if you use oxcarbazepine, it may worsen certain types of generalized seizures. So we do have to be careful about making the right choice. The other thing, too, worth noting is that when you look at all patients and you look at that first medication, you're only about 50-50 in terms of achieving seizure freedom. That's pretty discouraging to learn that. But then now, if you had to choose a second medicine, only about 13% become seizure-free. By the time you get to the third, your chance of being seizure-free is only about 1%. And adding a second medicine, you're only picking up another 3% or so. At the end of the day, when you break this down, a little over a third of patients continue to have seizures despite using combinations of medications. Having gone through 3 medications, now adding a second at the same time, 2 together, a little over a third continue to have seizures. That's pretty discouraging. It also shows the need for ongoing research for better treatment avenues. It shows us that we're missing something clearly. And, all those different etiologies I mentioned might be perhaps part of the equation. And we do have to think about non-medication options, the keto diet, vagus nerve stimulation. Occasionally we have to consider too, is this something that would require resective surgery? What's interesting here with keto diet though, is keto diet and low glycemic diet, they certainly treat epilepsy, but how they do it is sort of a question. And we have a lot of data showing keto diet improves mitochondrial functioning. Keto diet also lowers inflammation. Keto diet has effects on gut microbiome. All these things might actually play really well with kids on the spectrum. And so, and you can see weight loss as a possible side effect as well. So for kids who are carb loaders, heavy carb loaders, kids who are really food seeking, because they're probably crashing, they probably get that insulin surge after a carb load. They get a little hypoglycemic, they seek more food, and they can get really aggressive when they seek food. You put them on a keto diet, they're not going to have those cycles anymore. And so you might actually have a behavioral improvement as well. And then if you're improving mitochondrial functioning and lowering inflammation, that could have a good developmental consequence. But we don't have a lot of studies actually looking just at keto diet or low glycemic and autism. But as I mentioned, if you're doing keto or low glycemic, you're probably doing gluten-free at the same time because the two, naturally follow. So something certainly worth considering. The other thing that's really interesting is vagus nerve stimulation. So if you think of what's the major challenge, really one of the biggest challenges in kids who have self-injury or aggression, it's that fight or flight. And when we activate the vagus nerve, we're actually calming that sympathetic nervous system. So we're calming the fight or flight. So vagus nerve stimulation is FDA approved for epilepsy. It's actually shown benefit for depression, but I think there may be a role here too for easing that kind of fight or flight. So some of these non-medication options actually might play in well with other symptoms. Vagus nerve stimulation does require surgery. Presently, there is one non-surgical device that exists that's handheld, but not all kids tolerate it because of sensory integration. But I'd be happy to go through that if there are questions on that. And I mentioned before, I just want to come back to this concern about SUDEP or sudden unexplained death in epilepsy. But the reason I want to come back to is I want to really emphasize, what do we do to prevent this? What are the ways? Because there are quite a few ways to really keep our kids safe. And so again, as feared as it is and as scary as it is, I think discussing it's always the first step to really lowering the risk. I think it's important to know that who's most at risk. And this is not comfortable to hear when you have a young adult that you're caring for, but it really is in that young adult range that there seems to be the highest risk. So around 20 to 45. Males also have higher risk. So none of this feels very good because there are more males with autism. A lot of parents I see are taking care of a young adult. Those are the kids that we really need to keep protecting. We also do see it if kids are in a residential care facility too, that raises risk. And so these are actually my patients. These are the kids I'm taking care of. None of that feels very reassuring. So we have to find ways to balance that. And it can occur with any epilepsy type. I mentioned before, the overall risk is about 1 in 1,000. And having poorly controlled epilepsy really is one of the biggest risk factors. So that prompts the need to always search for better therapies. So there's a few ways we can reduce risk. So we know that co-sleeping has been shown to have a lower incidence of SUDEP. That's not a practical solution for many people, but it is a natural consequence of epilepsy, though, that many parents or caregivers do co-sleep. And I fully understand why. No judgment from me whatsoever, because having witnessed many seizures, it's absolutely frightening. And so I think that's appropriate if it feels right to you. I think if it doesn't feel right to you, or if it's too, just too intrusive, I think then we have to think, can we use some sort of monitoring device? Or what are the technologies that we can use that would help kind of balance the co-sleeping benefit? So for monitoring, there are a lot of different ways to do this. These have not been well studied, by the way, in terms of placebo-controlled trial type studies, but we have a few devices, and they can be used in combination if needed. So you have sound monitors, video monitors, wearables, movement detectors. Starting with the lowest, cheapest options, these like really simple sound monitors that we typically use for infants. What they're able to do is, if a patient at the onset of a seizure, if a patient has like an audible sound that they produce, this would pick it up and this would alert the caregiver. There are cameras too that are very specific to monitoring epilepsy. This is an example of the SAMI, S-A-M-I camera. And what this is doing is it's using an algorithm that would identify the movements. You can see these little red marks here. This is the camera detecting movement. And it's going to try to distinguish between somebody rolling over versus somebody having a seizure. And it will alert you when it believes it's a seizure. So it's not going to alert you for every single movement, but it will alert you when it detects what it believes to be a seizure. There are wearables as well. So this was an example of Empatica or Embrace. They make the Embrace watch, which is looks like really just like any other wearable watch. But what it's doing is it's actually measuring factors that would highly predict that the patient's having a seizure. So it can alert the caregiver. One of those factors is called the electrodermal activity. So what that is it's a measure of skin conductance. So when we sweat, the conductance is increased, and the sweat is really from the sympathetic nervous system. There's no parasympathetic input. So when we have a seizure, you get the surge of sympathetic activity, and that will increase skin conductance or the electrodermal activity. And this is an example of what that's measuring. So when you have a seizure, this is a generalized tonic-clonic seizure. When that occurs, this is the electrodermal activity, and that will jump. And so when you use a wearable, that's one of the factors it can detect that might help distinguish seizure. But in addition, they also can look at movement. Wearables can, and they can look at heart rate, other variables that would help. And you put all those together to help predict seizure. This one I do use quite a bit is Seizure Alarm. It's an app. It's not the wearable itself. This is an Apple Watch, but you can also use it for Android. And it's an app that you pay money for to predict seizure. It will alert the caregiver. You could set any number of phone numbers that you'd like, so you can alert multiple people. Inspire is yet another app for a wearable. And again, you can get a text, you can get a call, you can kind of alert whoever you want. You can record the data. The neurologist can see the data. Epicure is another. Of these, I would say the Embrace and the Seizure Alarm are the two I use the most commonly. This is rare that I've seen patients who've used a pulse oximeter, but there are pulse oximeters that can be worn and can issue an alarm if the oxygen saturation drops below a certain level. For patients who really characteristically have a drop in their oxygen saturation during a seizure, I do sometimes use continuous pulse ox. I'm more apt to use a true pulse oximeter machine as opposed to one of these wearables, but this does remain an option for some. Oops, we'll get to the dog later. But then there's also the MFit. This is the MFit itself. This is a mat that you put underneath a very thin mattress. And so this will detect movement, and it'll detect if there is sort of a rhythmic movement that is highly predictive of seizure. And then getting back to the dog, so there have been some data suggesting that patients who have dogs in the home are less likely to die from SUDEP. And so this kind of gets to the co-sleeping part of the equation, whether a dog can actually alert the family or caregiver to a seizure. A seizure dog, a true seizure dog, is a service dog that has gone through usually an extra year of seizure training. It takes about 3 years to raise a seizure dog. It's tens of thousands of dollars to purchase one. It's a time and a money commitment for a seizure dog. I have some families that have really just had a family dog that instinctively was able to alert people during a seizure. And I would just say that it's very breed dependent. And so if you look at seizure dogs, you're most commonly going to look at labs or Goldens as like two of the most common breeds. But many dogs are very sensitive when, even for those who sleep with a dog, like you'll see this, like if you move or roll over, they usually wake and they alert. And so many dogs will just kind of instinctively identify if something's wrong, particularly for seizure. I've seen many family dogs that will identify a seizure and begin to bark and alert people. It's important to note too, there are such things as anti-suffocation pillows. So these basically have very low resistance. So should somebody roll over and their face be pressed against the pillow, you can actually continue to breathe through it. Not a bad idea, really, for all pillows just to have this. In this example, the holes are very small, so you don't really see it, but there's very low resistance. This has very large holes, so it's a little more obvious. And it's a good example too to just emphasize as well that positioning is really important. This is the standard position that's recommended during a seizure. So we recommend the patient be placed on their side. Often we can prop the head a little bit with the hand in this way, and by keeping one leg flexed, it prevents the patient from rolling over onto their stomach. We like patients on their side because if they're on their back, they could throw up and possibly choke. And if they're on their stomach, it may obstruct their airway. But it's important to note that in SUDEP, it does appear that many of the patients who've died of SUDEP, the majority were on their stomach. And so very similar to SIDS, one of the things we want to do is encourage the patients not sleep on their stomach to prevent SUDEP. And then a final thing to think about is also having a seizure action plan in place. And this is not just for school. This is actually something to consider even for adult patients or patients who live at home who are perhaps adults no longer in school. But what a seizure action plan is doing is it's basically helping develop a plan at a time when you don't need that plan. You're thinking ahead, what do I do in a given situation if there's a prolonged seizure? Making sure you have a treatment plan, making sure you have the medication available. And you can find seizure action plans through the Epilepsy Alliance of America, the Epilepsy Foundation. Their websites can link you to seizure plans. And I recommend all patients have a seizure plan. It's really just having a plan in place so that we don't have to think and process everything that's needed during what is really perhaps the scariest time in a person's life. And so hopefully that gives some, I know I presented a lot, and I know that some of those topics, especially CDEP, are very uncomfortable to hear, but I hope I presented some things that would give some reassurance and actually give some actionable information to help prevent those kind of complications. There's obviously a lot more on this topic, so we could do probably many more hours on this topic, like just on the say the keto diet. That alone is a whole talk. Or just on vagus, the importance of the vagus nerve. That would be a talk. Or inflammation. Maybe there are just many more talks we have to do. But I want to give you at least that overview, and I hope that's helpful.
Thank you, Dr.
I will look for. Oh, yeah. Thanks.
So I think I'll review the questions, but before that, I thought I'll take a few minutes break to talk a little bit about the Brain Foundation for people who don't know much about what we do. And I think apart from seizures, we also hopefully bring hope to individuals with autism. So if you mind unsharing, I can share my screen and just speak for a few minutes about what we do. Okay. I wanted to go over one of the main activities of the Brain Foundation, which is that we give grants every year to help get to more studies, both repurposed drugs and new drug development, and eventually FDA approval for these drugs. Every year we have been funding close to 10 drugs, 10 new studies, both scientific and translational research. So this year we received about 170 applications, which was a record, and we had to go through peer review and select 10 projects. So the focus areas of our research are biomarker development, treatment trials, immune abnormalities, epilepsy, speech, motor, and behavior, and neuroinflammation and neuropsychiatric exacerbations. I won't go through the details, but I'll just give some examples of the studies that we have been funding. So this year we are funding one blood biomarker study from University of Texas Southwestern Medical Center, and a potential biomarker for neurodevelopmental disorders and ASD diagnosis using autoantibodies and cytokine biomarkers. And this lead investigator is Dr. Shannon Rose, and this will measure levels of inflammatory markers in plasma and NDD patients and identify potential treatments and explore autoantibodies as potential inflammation markers. We are also looking at treatment trials of few repurposed drugs, oxytocin, cobinamide, edaveron, bisafibrate, and metformin. The role of oxytocin is being studied by University of California, Berkeley, by Dr. Marquita Landry's team, and they will be developing a nanosensor tool for real-time imaging of oxytocin in the brain. And this is to develop an understanding of the interplay between social behaviors and ASD. Another one will be looking at inflammasome activity in autism spectrum disorder by Dr. Richard Death, and he's been studying this for a long time. So we wanted to support the study of oxidative stress and impaired methylation and the use of cobinamides, a vitamin B12 precursor, as a novel therapeutic target for autism. And this is a first study to look at this activity in the brains of individuals with autism and understand the increase in autism numbers. We're also looking at the interplay between genes and environmental factors by Dr. Adrian Eshraghi at University of Miami, Florida. And we are developing a study. It's a preclinical animal model to explore influence of genetic factors and environmental exposures like phthalates, and testing the use of edaveron and other FDA-approved drugs for this condition. Another study that we are looking at is identifying neuronal ensemble activity as a biomarker by Dr. Maltesh Kambali, and he will be looking at biomarkers for blood-brain barrier dysfunction and therapeutic approaches, and evaluating repurposed FDA-approved drugs, bisafibrate and metformin, which is FDA-approved for diabetes, as potential treatments. We are also looking at a couple of studies of immune activation and comorbid GI symptoms. Dr. Paul Ashwood, who's an expert in this area, he's looking at mechanisms behind increased innate immune activation and identifying potential biomarkers and targets for therapeutic interventions. In the areas of speech, motor, and behavior, we will be funding this study from Stanford University, Mind Over Chatter, Neural Decoding of Language Comprehension. And this will be a first test that will advance understanding of how non-speaking individuals process language and can inform development of tailored communication approaches. And they will also be developing benchmarking portable EEG against the gold standard MEG for signal quality. Another study related to Dr. Gaitanis today, he will be PI on this study, which will investigate the utility of spelled communication in autism, investigate the efficacy, and also determine whether spelled communication will improve behavioral regulation and improve communication and development. This will be the first ever retrospective and prospective trial of spelled communication in this population. There's also a study by University of California, Berkeley for emotion perception training for autism, and an epilepsy study looking at transcranial photobiomodulation by Dr. Richard Fry. And he will be looking at whether PBM has benefit for patients with epilepsy. So this will be the first study to investigate TPBM in ASD with epilepsy. We also have funding, we will be funding behavioral exacerbations, a study looking at functional activities of plasma from autism on blood-brain barrier, and a comparison with healthy controls. This is at Stanford University, Dr. Ian Mondal et al. And this study will characterize this unique subset of patients experiencing behavioral deterioration. So these are some research study that we have funded in the past. I will not go through that, but I wanted to bring this to everybody's attention that if you would like to be involved or if you have means of helping us with by volunteering or funding activities, please reach out. We will also be having our Synchrony Symposium July 12th to 14th. The last day, Sunday, is geared towards patients and parents and caregivers. Please go to the website and please register. I think today is the last day for the early bird pricing. So hope to see you all in July. So now we'll go back to the talk and handle the questions.
So there are quite a few. So there are over 40 questions. So I think what I could try to do perhaps is lump some of the ones that have come up a lot. It might be hard to get into all of them, so I apologize for that. But one that seems to present itself quite a bit has been the questions about vagus nerve stimulation, and so I think it might be worth addressing that a little bit more. Well, first of all, the vagus nerve, we talk about this a lot when it comes to fight or flight response, and there are a lot of times we'll try things that are non-invasive to improve vagus stimulation. So for, say, like a neurotypical patient who has a lot of trouble with fight or flight response, we work a lot on deep breathing. We might even encourage things like singing, for example, which can improve vagus stimulation. That's not always possible for a lot of patients with autism to do, but you do see more vagus stimulation that way. There are also some foods that are felt to perhaps improve vagal function. So if you can Google like a vagal diet, a lot of that leans towards trying foods that are low inflammatory type foods. Many of the kids though already are on like such diet, but really when we think of vagus stimulation, a lot of the focus is like, what can we do as far as really directly stimulating the vagus nerve? Can that improve both aggression as well as seizures? The current device that we use, which has been out for about 20 years, is the vagus nerve stimulator, which is surgically implanted. It's a pacemaker device that's in the chest. It has a wire to the neck that wraps around the vagus nerve. It requires surgery to implant, and only about 50% of patients are going to see a good response with this. And the challenge has always been, how do we identify who the good responders are? And we don't really have a reliable way to do that. So later for migraines, there was about 15 or so years ago, there was approved a product called GammaCore for migraine prevention, and it was a handheld vagus nerve stimulator. It's now been repackaged and remarketed under the name Truvaga. So it's like True, TRU, and then Vaga for vagal, VAGA. So Truvaga. It sounds a lot like Trivago, which is the vacation website. But anyway, so the vagus nerve stimulator, though, is handheld, and it's gives like a little bit of electric current to activate the vagus nerve. And theoretically, that would ease the fight or flight response. It could possibly help we have already data that helps for headaches, and many kids may be experiencing headache. It helps activate, and vagus input helps with GI motility. So that might be very important for a lot of kids and perhaps would improve some of the GI symptoms kids are experiencing. And you're easing kind of that fight or flight reaction. And then we know that it can improve seizures. I think the challenge with using the handheld, though, is that it will activate some of the muscles around the nerve. And some kids from a sensory standpoint are not going to tolerate it. In no way is this like an endorsement. I don't work with the company at all. I don't mean to endorse the product, but I would say that they do have a 30-day money-back guarantee. When it comes to any device, I would always look for that, because from a sensory integration standpoint, if a kid is not going to tolerate the device, you often know that within a few minutes of trying it. And last thing you want to do is waste like $300 on all these devices individually if the child's not going to tolerate them. But that one can be purchased and returned if it doesn't work. There have not been studies of that for epilepsy, and there have not been studies that have ever seen if that predicts whether the surgical vagus nerve stimulator works. However, off-label, I have tried it that way because we don't have a way to predict if the surgical one works. So sometimes I've tried that. I hope that kind of addresses some of the vagus nerve question, but I think there's a lot more there to explore. And I understandably, that's an area of interest. The other area that seems to come up a lot in the questions too is about the diet. And I would just say that for patients who have not responded well to seizure meds, keto diet should always be considered, should always be explored. I think this is one of these treatments, when you looked at the study that we did that looked at which treatments are most effective, I think it's really interesting that keto diet was at the very top, above the meds. But I think it's also interesting because keto diet, as I mentioned before, it lowers inflammation, it improves mitochondrial functioning, it does have effects on gut microbiome. I think there's some factors here that do need to be studied in autism, period. What's the effect, say, of self-injury and aggression or OCD, or how does it affect PANDAS behaviors? I think there might be broader effects of keto diet that we haven't really explored fully. And so I'm very optimistic, and I always encourage keto diet, or at least a trial. I just don't use the strict keto diet. I like to use the low glycemic because it's so much easier to do. And even if you tried like an SCD diet, it's okay if you haven't gotten fully ketotic. You probably can still see some benefit, but to really get, I guess, the best benefit it is for seizures and epilepsy, it would make sense to do like a true low glycemic to try to at least get some ketone bodies in place, because we think that's part of what it will help predict efficacy there.
So before the webinar, we asked for questions, and some of those questions I think can also be clubbed in this category of regression. You mentioned second regression. I think in many of our cases, we would call it relapsing remitting because it's not just twice, it happens, and it's not always in the end complete regression. Some of our kids do end up, regaining some of those skills also. One of the questions that came up a lot was after one seizure and after getting that in control, if it hasn't happened for some time, how long do we wait before we start to wean off those measures we have taken or medications that we've started doing? When is considered safe to look into reducing?
Yeah, I would say, so any medicine that we use that either causes side effects, makes the situation worse, or doesn't work, we should get rid of, because most of the kids I see, they're on a host of different supplements and medications. We really need to clean those up. And so if I introduce a new medicine, if it makes anything worse, I'm very likely to get rid of that quickly. If it doesn't work, and this is why we sometimes do one thing at a time, but if it doesn't work, I think within a certain time frame, we do have to get rid of it. I would say usually, certainly by 3 months, you're pretty safe to get rid of it. Sometimes sooner. It depends on how frequent the seizures are, though. So if you have a child who has like daily seizures almost, 3 months is maybe much longer than you need. I might know that answer even in a month or month and a half. I might have a good clue on that. In general, if the medicine doesn't help the seizures, taking it away should not worsen them. We do have to worry about rebound seizures, but we're going to worry the most about rebound when the medicine works. If the medicine doesn't work, it shouldn't cause a lot of rebound in general. And you do have to worry more about rebound with certain meds than others. So for example, clobazam or Onfi can cause a lot of rebound. There were some questions too specific to the Onfi. I do use clobazam, which is the generic name for Onfi. I do use clobazam, but we have to be careful because it is a benzodiazepine. It can be sedating. And so we have to be careful about side effects. We don't want, in general, we're really trying to avoid medicines that will drug a child, make them more sedated, or blunt cognition. That is not the goal. The goal, this is, and I don't want to speak out of turn against my psychiatric colleagues, but, what the standard psychiatric approach for, say, self-injury and aggression is to use atypical antipsychotics, which will blunt cognition. If If somebody offered me Risperdal or Abilify for me to take myself, I would not want it because it's going to blunt my cognition and it's not going to allow me to think and process as I should. And then there's the other issue, which is the massive weight gain it causes, which is a real issue because then that leads to type 2 diabetes, etc. But then there's another thing too that psychiatrist doesn't often think about, which is that some of the atypical antipsychotics can actually bring out more EEG abnormalities. It can actually sometimes trigger seizures, certain psych meds more than others. I would say Wellbutrin is the most worrisome for triggering seizures, but we have to be careful about not making things worse with what we're treating. And certain meds like the atypical antipsychotics, I would say they don't do anything to improve mitochondrial function. They don't improve inflammation. They don't really get at some of those core underlying pathophysiologic considerations. And they don't do anything for seizures. In fact, they might make them worse. So in general, we want therapies that are like a win-win, right? We don't want like a little bit of a win and a loss. Like we really want a win-win kind of treatment. So that's where I would say a keto diet or something that enhances vagus stimulation. I almost, for a second, it cut out.
You're okay now.
Oh, good. Sorry. Yeah, cut out for a second. I apologize. Yeah, so in general, you're looking for win-win situations. So you really want to improve core symptoms. Like, you want something that is not going to negatively impact cognition, something that would lower inflammation, something that enhances mitochondrial functioning, right? So seizure meds don't do those. Seizure meds don't achieve that. And many of the therapies we use specifically in psychiatry for the aggression don't do that. And so that's where I think we do have to really begin to explore other approaches. That for many of these approaches, we don't have enough data or enough study, but I think this is why I emphasize that we have to think differently in kids with a history of autism because the pathophysiology is different. So it's necessary that I think that the neurologists really approach this in a different manner.
I think there was another question on the rescue medication, like should we have access to it and how to use it? And sometimes it causes other problems, and is it still worth using the rescue medication?
Yeah, I think, so I recommend for kids who have epilepsy to have a rescue medication, to always have one. We used to only have rectal versions available, but in the last, 2 years ago, there was approval for 2 different nasal sprays. And so those are really easy to administer. And so having a rescue medication, I think, is an important part of the treatment plan. The rescue medicines we use are benzodiazepines, so they will be sedating, but it's still. And one of the concerns with benzodiazepine is respiratory suppression. However, when you have a seizure, the effect of respiratory suppression is far greater from a seizure than it is from these meds, and there are ample data showing that you're much safer to treat the seizure than not to, and also to treat it relatively early. So we usually say about 5 minutes for a time frame to treat. And so that's part of what we have to have in a seizure action plan, is always to know, like, what's the time frame when we treat, what are we going to use to treat, and to have those medications available. I'm going to kind of speak totally off label here, but for adults, many times a nasal spray might be like 2 sprays that we give for a seizure. Benzodiazepines would help if a child's really building behaviorally. Benzodiazepine will actually calm that very quickly. So I have done this on occasion where I've actually used like a half dose or 1 spray for a child or a young adult when we see the behaviors escalating quickly, not a seizure, but just like a really rapid behavioral escalation that we need to get control of quickly. Sometimes you're in public. That's totally off label, but I'm just putting that out there. Totally off label, but I have done that because it's risk benefit. So the same spray that would break seizure would also potentially break a really bad fight or flight episode.
There's also a question about lacosamide. Why is it not used more often? And I've also heard from parents about lacosamide causing some slowness. Is that okay, or I think it's unrelated to cognitive decline, but just slowness. Is that considered an okay symptom, or is it time to look for a different drug?
Yeah, I'd say lacosamide is used a lot in focal seizures. So for anybody who has generalized seizures, it may not be the right choice. Um, for focal seizures, it's not a bad med. It can be given IV, which is one of the reasons that it's popular, because you can start it very quickly in the hospital. And so it has some advantage there. Most people don't report, most neurotypical adults don't report too much sedation from it, but certainly sedation is one concern. And then it actually affects cardiac rhythm. So anyone whose child is on multiple seizure meds, it's very important to check with the pharmacist to see if these meds affect cardiac conduction, and recognize that certain antibiotics will also have similar effect, and some of the psychiatric meds have similar effect. So we can't safely have, say, 2 or 3 meds that all affect cardiac rhythm. And it's important to do an EKG if that's the case. And we have to make sure that the pharmacy checks for that. Lacosamide is one of those meds, so we have to be a little more cautious in using it for that reason.
Are there any other questions? Dr. Milky, you had a question?
I wrote my questions down.
You could ask them since you're able to unmute yourself.
Oh, cenobamate. I got it. Okay, I found it. Yeah, so cenobamate is also it's branded as Xcopri. So it's a relatively newer med. It's been out for a couple years. I would say of all of the meds that are out, if you have a child who has refractory partial seizures, refractory meaning you've tried three or so medications and the seizures continue, even to the point where someone's considering surgery for them, cenobamate is a really important med to try, because I have found it to be effective even in patients for whom nothing else has been effective. That's more so for partial seizures, not as much for generalized, I'm saying that. It does have risk of allergy, so we have to go slowly with the increase. But I do tend to be a proponent of it for that reason. And then the Empatica, you make a comment too. So I would agree with this comment. So the comment is that there are a lot of false alarms with the Empatica. That has also been my experience as well. I have generally been recommending, and these are just my own recommendations, and I don't work for any of these companies, but I generally recommend Seizure Alarm more so. Seizure Alarm is the app that you can use an Apple Watch or an Android Watch for. But I am sometimes scanning to see if the parents come in the room with their Apple Watches on. So the parent already owns one. So then you only have to pay them a month to try the Seizure Alarm, as opposed to Empatica, where you're purchasing a whole other device, buying the watch, and then you're paying a monthly fee on top of that. So I just generally try the Seizure Alarm app. Some kids, for sensory integration reasons, are not going to wear a watch. And in that case, I tend to use the SAMI camera more. If it's really more for nighttime monitoring, I think that's a good option. I wish there could be more seizure dogs, or they're easier to use, but I actually think a canine companion could be good all around. Good for vagus nerve function, good for fight or flight, but also good as a seizure monitor. I think canine companion is often a good approach too. It's just that a dedicated seizure dog is very expensive. And if you are getting a dog, like sort of a shot in the dark to see if the dog would work, you have to be very breed specific there and think about which ones are most helpful. But so there's a few things that you could still do to monitor safely. The watch is still one piece of the equation. You can use things in combination too. So that's another thing to keep in mind. All of those things I mentioned for monitoring, you can use a anti-suffocation pillow, you can have a canine companion, you can still wear a watch, you can still have a SAMI camera. I don't want to bankrupt everybody, but it is possible to combine these as well. So that also remains an option.
There's another probably last questions people have asked about if they've never had a seizure. How would I recognize a seizure? What is a seizure? And maybe also include what does one do on the first seizure? If you go to ER, do you request a neurologist consult or do you try to advocate for treatment given that it's a high comorbidity? What do you do in the case of the first seizure?
Yeah, I'd say for a family, so if you have a pre-existing diagnosis of autism and then you have a first seizure, my personal belief is the risk of epilepsy is higher than it is for general population, just based on experience. We don't have studies that have shown that, but that's what I've observed. And then also the MRI is more likely normal and the EEG is often normal. So what happens typically is they're going to send you home from the ED. You wake up from that first seizure, they say, they do the studies, they're negative, and they're going to say you don't need medication, just wait for the second seizure. And I'm never quite comfortable with that plan. I think at a minimum, if someone has that first seizure, they should at least have a medication to break it. So like a seizure action plan, and then either Valtoco or Nasolam, which are the two nasal sprays to break a seizure should one occur. And I do think we have to be a little more suspicious too, like what else could cause it. It does require a careful review of the psychiatric meds to make sure there's nothing there that would have triggered it as well. And of course, you do want to just look at the general health and well-being of the patient. Like, are there a lot of GI issues? Has there been a lot of pain? Has there been a lot of sleep disruption? I'll just mention really quickly here for sleep, because I could easily go off topic for too long. However, for sleep, I think when it comes to these seizure watches, these watches are designed to identify a seizure and alert you when it happens. But a wearable can also give you sleep data. And I think that's a really important thing to measure too, because a lot of my patients, their sleep is disrupted for like 2 or 3 days before the seizure. And I think for general forecasting, that's a really important thing to identify when you're at risk. But when you come in with that first seizure, I think it does require looking at, are there signs of inflammation? Is there GI pain? Is there sleep disturbance? What else can we do? What else can we try to address here? And recognize too that the risk of epilepsy is likely higher than the general population. Most people still don't treat unless there's a second seizure if the studies are all normal, but we have to study that. That really requires some more exploration, because I don't know that we're recommending the right thing, to be honest.
As a parent, I would also recommend just wearing a Fitbit or any kind of sleep monitoring all the time, because as you mentioned, several days of lack of sleep, even if it's due to jet lag or any other situation, could trigger a seizure. I think we are at the end of the allotted time, and we've covered most of the questions. So thank you so much again for speaking, Dr. Gaitanis. If any of you want more information, please reach out to us at you can email info@brainfoundation.org with any questions, or sign up on our website for more webinars of this nature. Thank you all so much. And I will end the webinar now. Thank you.
Sure, it's my pleasure. Thank you.